So I'm excited to talk about the Inavo 120 clinical trial results. We presented an expanded analysis of this trial, starting with progression-free survival data that I just want to reiterate it, that provide compelling evidence that this triple combination of inavolisib, a novel PI3 kinase alpha inhibitor, plus palbociclib, plus fulvestrant, prolongs progression-free survival from 7.3 months to 15 months, essentially more than doubling progression-free survival. The benefit was even more compelling in premenopausal patients, going from 6.5 to 20 months, and that was associated with improvement in objective response rate, going from 25 to almost 60%, which is quite compelling. What is interesting about the presentation here at ASCO, that we added more detail about patient experience during the clinical trial. What was interesting to see that the patients report through various patient-reported outcome assessments that there is significant delay in deterioration of their pain. So more than 12.8 months, more than a year later, patients have increase in their pain with the triple combination compared to double combination with placebo. Okay. In addition to that, we see that their quality of life, day-to-day functioning is completely maintained, and there is minimal increase in the overall bother that's associated with the treatment itself. All right? So when you look at individual side effects, just to get a little bit more kind of granularity about what's happening, you see the most common on-target side effects of PI3 kinase inhibitors are actually much less pronounced with inavolisib. Okay? What we see that, for example, for hyperglycemia, only 1.2% of patients discontinued that therapy for that side effect, increased blood glucose. That's 5 times less than what we see with earlier generations of PI3 kinase inhibitors that are currently available. Okay. In addition, there is 0% discontinuation for rash. Again, this is really important because patients with alpelisib, the earlier generation PI3 kinase inhibitors, have great deal of difficulties with rash. Similar results we see with diarrhea. 0% of patients have to discontinue for diarrhea, and there was only about 0.6% for stomatitis. So overall, when you look at these side effects and you see that patients do not have to discontinue therapy, which means that then adverse management guidelines are really working. And this is a message that I also want to send and that I clarified during the presentation. When you start triple therapy, you're hoping to prevent a whack-a-mole game, so to speak. You're trying to squeeze the cancer at 3 different molecular switches: PI3 kinase, ER, estrogen receptor, and CDK4/6. So you're kind of closing the door for cancer to sort of escape. But when you do that, you always worry you're now adding not 1, not 2, but 3 different agents. You worry about side effect. So when you see that the patients actually can tolerate this, and you have then doubling of progression-free survival, maintenance of their quality of life, so that's really the combination that we are looking for. I believe, sincerely, that in patients who are high risk, patients who are progressing shortly on or shortly after adjuvant therapy, patients who have measurable disease, particularly visceral involvement, and who have a PI3 kinase mutation, particularly bad prognostic sign, when you have those features, it's going to be really important that this triple combination is used in those patients. The drug just last month received breakthrough therapy designation, and it certainly holds great deal of promise for this patient population.